Welcome, everyone. I'm Catherine Staton. I'm an emergency medicine physician and implementation scientist, and I'm honored to be here today for this Think Global event. So thank you to the organizers for having us. On our esteemed panel, I have with me today Dr. David Kalima, Dr. Kenneth Kalani, Dr. Florence Jaguga, Dr. Kim Madundo, Dr. Joao Visoshi, and Dr. Jeremy Bray. Together, we're here to talk to you about alcohol and alcohol use behavior globally, the impact that it has globally, as well as specifically on low and middle income countries, and how we are putting some evidence into practice. So thank you for joining us today, and we will get started. First, to really talk about a little bit of an overview, alcohol use and related harms are a worldwide behavioral problem. We choose to use alcohol, and it is causing 2.6 million deaths due to alcohol globally. A large proportion of that is from non-communicable diseases like cancers, and that's 1.6 million, but a significant number is also causing injuries. And this is the deaths alone. This doesn't talk about the disability and the impacts both on the individual, the family, and the community level risks that are happening globally. As you think about it, 7% of the global population has an alcohol use disorder. It's over 400 million people. While those numbers are incredibly high, the number of treatment options and/or treatment providers or personnel is incredibly low. We know this not only for low resource settings, but even high resource settings. We have a mismatch between the availability of treatment services for alcohol use and for those who have need for this disorder. Next slide. Much of what we'll talk about today is coming from the WHO. As we know, we have a significant amount of data of what works. Based upon this and the understanding of the burden of alcohol use disorder globally, the World Health Organization has created the SAFER Initiative. This SAFER Initiative has brought together 5 areas of science, of evidence-based intervention that we know works. They're using these interventions and suggesting to use these interventions in low and middle income countries to reduce the burden of alcohol on the population. So the SAFER Initiative per se talks about strengthening restrictions on alcohol availability, advancing and enforcing drink driving countermeasures, facilitating access to screening and brief intervention and treatment, enforcing bans or comprehensive restrictions on alcohol advertising, sponsorship, and promotion, and raising prices on alcohol through excise taxes and pricing policies. As you look at this diverse array of intervention to reduce alcohol-related harms, you can see that it is a multidisciplinary approach to be able to reduce the use of alcohol and the impact of alcohol on our lives. I want to bring attention to number F, or letter F. This is the only one that is significantly in the health system, and this is to facilitate a screening and brief intervention and treatment. The reason why this is the only one is this has the best evidence of cost effectiveness, specifically for low and middle income countries. Similarly, it's focused on prevention of harms through brief interventions. A lot of times, as we think from the health perspective, there's nothing we can do, it's only specifically treatment, etc. This is not the case. The data shows that brief interventions and screening within our healthcare system at the primary care level can have community level impact. So we really need to understand how we can implement these interventions amongst all of the SAFER initiatives and what the challenges are in doing so in our low and middle income settings. Next slide. So I am honored today to be able to bring my colleagues and friends to be able to talk about their experiences in low and middle income countries. First, I'd love to welcome Dr. David Kalima to talk about his experience.
Hello, ladies and gentlemen. I'm so happy to be part of this educative webinar. And my role today is to talk about the harm, the burden, the alcohol burden in low and middle income countries. I start with that slide from the World Health Organization Global Status Report on alcohol and health, which shows that the highest levels of alcohol attributable deaths per 10,000 persons are observed in the African and European region. And my primary area of address today is in the African region. As you can see from that graph with the African region, you see that Africa hosts the biggest proportion of alcohol attributable deaths due to digestive diseases, also due to unintentional injuries, and also due to unintentional injuries and digestive diseases. And for Uganda in particular, as I'll address myself to Uganda's case study, you'll see that many men, out of 100,000 deaths in Uganda, 156 men will die because of alcohol harm, and 32 will die also because of the same. So the problem is huge, as we are going to see. Next slide, please. Yeah, I pick out Uganda because I couldn't address all the countries at the same time, but this is just a case study. And this slide shows that globally, average alcohol consumption per capita is 5.5 liters. But when and for Africa, it's 4.5 liters. However, when it comes to Uganda, this is high, and you'll see later on the exact figures, but this shows you that Uganda is the #1 alcohol consuming country in Africa. Next slide, please. Okay. Maybe before we really see the details of alcohol and the dynamics of alcohol consumption in Uganda, let's look at the population trends. Currently, we are about 50 million people, but it is assumed that by 2050, we shall be 85 million people. So Uganda is not only one of the youngest countries in the world, but it also has one of the fastest growing populations in the world. And the two population pyramids will show you how the population will change in Uganda. And you see that we'll have many of people in alcohol consuming brackets coming up. And this is really a big interest for the alcohol industry. They see us as really a potential market for the products right now and in the future. Next slide, please. Okay, this is probably my last slide. I just wanted to give you a sneak peek about how Uganda compares with the rest of the world when it comes to alcohol statistics. With the world, it's the 44% is the global average population of people who are consuming alcohol, and Uganda happens to be a little lower than that because it's 42%. But when it comes to pure alcohol per capita consumption, Uganda doubles the world levels. This is, you can see that when it comes to the general consumption, I mean, to the number of people who are consuming alcohol, Uganda is below the global average. But when it comes to the amount of alcohol consumed, we actually double. And also, you can also see that alcohol use disorders double. Uganda has 13.7 as compared to the global average of 7%. You look at the heavy episodic drinking in the general population, it's 22% of the general population are heavy episodic drinkers, while the global average is 17%. Drinkers, heavy episodic drinkers, among 15 years plus, 56%, compared to the global 38%, and heavy continuous drinkers are 9.1. No wonder even the alcohol attributable mortalities in Uganda are higher than the global average. As the global average is 4.7, with Uganda, we have 7.5. Next slide, please. I think that's what I could say about the alcohol harm and alcohol burden in our country as a case study for low and middle income countries. Thank you very much, and back to you, Kenneth. Sorry
Excellent.
to Catherine.
Thank you, Dr. Kalima. Next up, we have Dr. Kalani.
Thank you, Catherine. And I'm just going to talk about the challenges in curbing the burden that David has just mentioned. One of the biggest challenges is lack of awareness, and this cuts across all levels. Alcohol in Uganda and many third world countries is normalized. And so it's deeply embedded in our social cultural fabric. And as such, the general population, even the policymakers, they do not comprehend the harms associated with alcohol use. And as such, there's little buy-in, so to say, in alcohol control measures. So as ministries and governments recognize the burden and the health effects of alcohol, but the policymakers and even the general public, their perception of the harms is really low. And as such, most of the interventions that have been put across to control alcohol-related harms are not, welcomed, and that still, propagates alcohol use in the third world country. Secondly, is about the legal framework. Uganda and many other third world countries have existing policies that try to control harmful alcohol use as a way of prevention, really. And these are public health policies. But it's very difficult to implement a regulative public health policy as alcohol restrictions. As in broader terms, when you seek to control alcohol, you need to advance measures that control marketing, advance measures that control initiatives on legal drinking age, hours of sale, that control sponsorship, and so on and so forth. And these are very regulative provisions of the policies that without an enabling law, it's a bit difficult to implement. So these are some of the challenges that in the preventive arm, as we try to prevent and control the supply and even the demand of alcohol, it's very difficult to do that without an enabling. And very many low and middle income countries do not have this enabling legal environment to adequately control the harmful alcohol use. Thirdly, there is limited capacity to identify harmful alcohol use at primary healthcare levels. As you notice, the health system in many third world countries is still struggling, and it's a bit difficult to manage severe alcohol use problems because you need a lot of infrastructure and resources to manage patients with severe alcohol use disorders in a controlled environment, in a way of rehabilitation, and so on and so forth. As a matter of fact, like my country, we only have one government-owned rehabilitation center. And so we bank on the primary healthcare centers to identify and provide care, but there's little capacity at those levels. So that means patients go on and on and on. And by the time they present to the tertiary institutions, they have severe alcohol use problems. And still there is limitations infrastructure-wise and even human resource-wise, or to manage these patients with severe alcohol use problems. So we really face the harms, we watch the effects of harmful alcohol use in the country. And that's why the prevalence of alcohol use disorder is going up, and also the harms, the health harms, and even socioeconomic harms associated with alcohol use goes up. Finally, I want to talk about the aggressive tendencies of the alcohol industry. So, because of they take advantage of the lacuna in the legal environment to aggressively market alcoholic products, to advertise, to sponsor, and also interfere with alcohol control policies. As such, they continue to propagate alcohol use and market products, and particularly targeting young people. So there is widespread underage alcohol use in the country, and particularly these are, I would say, deliberate efforts or moves by the alcohol industry to push their agenda by marketing and increasing their sales of alcoholic products. Largely, these are some of the key issues that have affected uh, the curbing, or efforts to curb the burden of alcohol use in Uganda, and I believe in many other third world countries in the world. Thank you so much. Over to you, Catherine.
Thank you, Dr. Kalani. Next up, we have Dr. Jaguga.
Thank you. So I'll be talking about how to close the treatment gap in Africa. My colleagues have talked about how the burden of substance use disorder is high. And Dr. Kalani has talked about how there's a great gap in terms of treatment services. Next slide. I think this has been mentioned, that the burden of substance use is quite high, and the treatment services are scarce. I won't overemphasize that, and that up to 90% of those with an alcohol use disorder go untreated. So just like what we has been talked about in Uganda, even in Kenya, the services are quite scarce. We have only about 4 to 5 government-run rehabilitation, drug abuse rehabilitation inpatient treatment services. We don't have outpatient services, and in the primary healthcare facilities, we don't have screening for substance use disorders, and we have very few mental healthcare providers. And so community and peer-based models can be one way in which we can close the treatment gap. And I'll be sharing a bit about some of the models that we have piloted. Next slide. So I have engaged together with other colleagues in a number of projects in Western Kenya, both research and care projects that have piloted peer-based and community-based interventions to address alcohol use and substance user interventions for both men, but also for young people and for men with substance use problems. So this particular one was targeting specifically fathers with alcohol use disorders, but also comorbid depression. And we piloted it together with some partners also from the US. It was a 5-session intervention, and we trained lay people from the church, actually, to implement the intervention. It had a combination of cognitive behavioral therapy and a bit of motivational interviewing, of course, psychological techniques, and we found it to be feasible and acceptable. And this is going to move forward to a full-scale trial. So quite promising interventions. Right now, we are actually in the middle of conducting a full-scale trial for this one. Next slide. Again, so this is one again that we have piloted. This one was funded through NIH. This one was a screening and brief intervention for youth living with HIV. Again, we were piloting integrating a screening and brief intervention program for young people aged 15 to 24 in a primary healthcare setting. A single session. Again, we wanted to see if it can be feasible to implement such an intervention at primary in a primary healthcare setting. And again, we found it to be feasible and acceptable. So we are trying to see if we can integrate these interventions in primary healthcare settings and using non-specialists to implement these interventions. Okay. Again, we found it to be feasible. Next slide. All right. Again, this was another interesting program that we implemented. This one wasn't a research program. This was donor funded and was a partnership between the government and let me call it a non-governmental organization. This was a partnership, and we received funding to implement, again, a community-based mental health care program, but that had a component that was focused on alcohol. And we brought together people who had challenges with moderate level of alcohol problems, and they formed groups in the community. And then we use the 12-step approach. Next slide for a better description. And then we use the 12-step approach to help with recovery. So this was quite informal, and then there was a socioeconomic component to the group as well. Okay. I'm not able to give the details in the interest of time. So this was a very informal way of people coming together in a group using sort of like the AA model for them to recover. Okay, next slide. All right, next slide. Unfortunately, in the interest of time. Next slide. So overall, what we have learned from the work that we have done in Western Kenya, that it is possible to use community-based approaches. So community means primary healthcare settings. It means outside of hospital settings. It means in churches. It means in villages. It means in social halls. It means under a tree. It means you can use primary healthcare workers. It means you can use non-specialists. You can train them and you can equip them with the skills, and they're able to implement very simple alcohol interventions, behavioral interventions, and they're able to implement them with fidelity. An important component is that they need to be supervised, of course, by a more, someone with a very fairly good skills in terms of mental health training. Usually we have a psychologist at diploma level or bachelor's level who then supervises them and gives them, support as needed. And then also what we have learned is if you're implementing an intervention at community level and it's a group-based intervention, then it's good to add a socioeconomic component just to keep people coming back and, to be together. And also the other thing that we are doing is trying to test this intervention to make sure that they're effective and they're cost effective. and also trying to test them more rigorously to ensure that they are feasible, to show that there is support for them even at stakeholder level, to make sure that we are documenting the successes so that they can be replicated and that they can be scaled up. So we are saying that the treatment gap is there, but we are not waiting to train 1,000 psychiatrists. We're not waiting to train 1,000 psychologists. We can use the simple tools that we have. We can make sure that we have solutions that are contextual. Thank you.
Thank you, Dr. Jaguga. I love it, under a tree. We should use that more often. Next, I would like to welcome Dr. Madundo.
Thank you. My name is Kim Madundo. I'm a psychiatrist and early career researcher based in Kilimanjaro, Tanzania. I'm going to do my best to sound coherent, but because of the time, it's quite late here, not because of alcohol. I'm going to talk about two groups, that's adolescents and women. We consider these two groups vulnerable groups. So we have literature that shows us, both local and global, that individuals at the age of 18 are already drinking quite heavily. And in Tanzania specifically, it's very common for children to begin consuming alcohol before the age of 18, but even within their first decade of life. We don't have the true numbers to tell us exactly the magnitude of this issue because, first of all, it's highly stigmatized to drink as an underage individual, but also the legal age of drinking is 18, and so many adolescents fear being reported to the legal authorities. We also have literature that tells us that lack of regulation or a lack of enforcement of these regulations of alcohol use correlates with alcohol-related consequences, and this includes violence, suicide, physical injuries, unplanned pregnancies, and sexually transmitted infections, which are all very common in the adolescent group. And we know that adolescence is a period of life where there's a lot of experimentation and a lot of engagement in risky behaviors. When you think of the prefrontal cortex, it is still developing at this time of life. And so there is little appreciation for consequences, and reasoning is not always great. The disinhibition that is brought on by alcohol and the damage that can occur with prolonged use of alcohol on an adolescent's brain will only heighten the risk of these challenges. However, in Kilimanjaro specifically, there's sociocultural practices that predispose adolescents to begin consuming alcohol at an early age. And alcohol is used, as in many places in the world, it's part of celebrations, but these practices where children actually serve their elders alcohol and they are encouraged to taste or to drink a bit of the alcohol before they serve it to their elders means that children begin developing a tolerance towards alcohol from a very early age. When talking about women, we have studies that show that upwards of 40% of pregnant women consume alcohol during their pregnancies. The amount of alcohol consumed is even higher in older women. However, younger and non-pregnant women have the highest rates of hazardous alcohol use. And we know that the WHO tells us that there is no safe quantity of alcohol use. So we may need to redefine hazardous, but in this context, I'm speaking of alcohol use that complicates to physical, psychological, behavioral, social consequences. And so whether we're talking about pregnant women or younger women who are not pregnant, the alcohol consumption, we have enough literature we have enough evidence to show that the alcohol can cause harm to the fetus, to the woman herself. And because in a context like this, where women are heavily involved and traditionally involved in caregiving, even women who are not yet pregnant but plan to have families, their alcohol consumption can cause harm to future generations. So I will highlight two projects briefly that target these two groups. And these are both adaptations of an evidence-based brief negotiational interview that was led by Dr. Catherine. And this was a negotiational interview that was happening in an emergency care setting. And we plan to adapt this intervention to identify these individuals, adolescents and pregnant women, in an emergency care setting or in an maternal care setting, and to be able to identify them as soon as possible. Why this is important? Because, first of all, mental health services are critically lacking, but as part of usual care, screening for alcohol use and many mental health challenges is not integrated into non-mental health settings. And so people tend to present at very late or complicated, severe stages of their conditions, and they are only able to receive support if it's even available when they reach us. So there's also opportunity for innovation towards strategies that we can reach these vulnerable populations or high-risk populations at an earlier stage. Thank you.
Excellent. Thank you, Dr. Madundo. Thanks for staying up late for us. Next up, Dr. Fasoshi, to talk a little bit about innovations in the field.
Yeah, well, good morning, good afternoon, good night, wherever you're watching us. It's really hard to come after this body of knowledge that you just received on different interventions and different ways our colleagues are tackling this issue. And as you were seeing, is a big, big issue globally. I have the pleasure to try to push us to think about this from a slightly different lens. There's a lot being done in trying to engage and bringing interventions to the community level, trying to expand these interventions like the SAFER model to a higher health policy perspective. And in collaborating with all of these amazing partners, I have the pleasure to be the one that tries to keep pushing us across the edge a little bit of the innovation in this aspect. And for me, it's really interesting to think about how we can address alcohol harms in the low and middle income countries when you are facing this moment where we engage with artificial intelligence and we engage with our capacity to, in very massive ways, understand, capture, and get insights from data. And that's coming from everywhere. So I really believe that there's a large role to play in how we tackle these harms in the low and middle income country if we are able to leverage available data through different types of analytics, data science, artificial intelligence, and the cutting edge technology that we have developed as a society. To give you a few examples, what we've been trying to do recently is to take some of this knowledge around using brief interventions that you were able to see Dr. Madundu talk about, and also Dr. Jaguaga, and that is part of the core work of the SAFER, to bring brief interventions to decentralized venues, to the community setting, to areas where non-experts can use, and leverage that, facilitate the development, the training using artificial intelligence. So I want to highlight the work that one of our current members of Gemini, Dr. Souza, has been doing on trying to translate the brief intervention concept to large language model, artificial intelligence, ChatGPT kind of model to provide this intervention using SMS, which we all know is widely distributed across Africa and across the low-income world, but also using apps that could also be beneficial. Beyond that, this could be a very important way to train or supplement the constant need for training with lay healthcare providers or community health agents. So this is something that we are actively engaged on right now, and there is evidence that this can be done. Another way to think about this from an innovation perspective is that with our ability to model more complex data and model and try to find patterns of different types of data, multimodal data, data coming from different modes, such as voice, such as text, such as raw data that I can get from engagement with the healthcare system, or imaging data, we can try to also understand alcohol from a more multimodal perspective. As you saw Dr. Madudu mentioning that alcohol use affects us from a behavioral perspective, from a neurological perspective, from a epigenetics perspective, and understanding alcohol use and alcohol disorder in a multifaceted way, such as the research domain criteria model that is vastly supported by the NIH suggests, we see alcohol disorder as a problem that can be represented or manifested in different faces that talk to each other. So what I drink, my drinking behavior, is the way is what I can see, but it also hides what's happening in my brain. It hides what's happening in my trauma experiences. It hides what's happening even on my expression of my genes. So currently we are able to tackle this using innovative ways, such as the Alcohol Use Behavioral Phenotyping Project, AUBPT, that has been led by Paige O'Leary from our center, was initially started by one of our students that is now a PhD candidate, Siddharth Zadeh, and is continuing to a multinational translation of a game, a digital gamified solution that as you play the game, we're trying to map out your neurological pathways, your neuropsychological pathways that could be linked to your alcohol use, and this way finding phenotypes of alcohol use, different ways of alcohol use disorder that could trigger different interventions as well. And I'm going to stop here as there's several innovations that we could be tackling, and we can discuss this further. But thanks for allowing me to push us a little bit over the edge, Catherine.
Thanks, Dr. Visosci. And last but definitely not least, I want to welcome Dr. Bray to talk a little bit about cost-wise.
Thank you. Thank you, Catherine, and thanks everybody for attending. And thanks to my other speakers. I have to say, when I put together my thoughts for this talk, I had one thing in mind, and now that I've listened to all the speakers, I'm throwing that all out the window and kind of starting fresh. But we covered a lot, and I think one of the things that came up often throughout the speakers were the phrase cost effective. And that ties into, sort of my, what I do as an economist. We know that money alone is not going to solve a problem, but by the same token, there are a few problems that cost nothing to solve. And so we need to understand what are the resources we're devoting to trying to solve a problem, and what benefits does solving that problem give us. And that's what economic evaluation is about, is clearly articulating these trade-offs so we can be thoughtful about what we're spending our money on. The key in articulating those trade-offs, though, is to think about what economists call opportunity cost. So what is it that we're really giving up, and what is it that we're getting? And we tend to always see these in money terms. And in money terms, alcohol screening and brief intervention, as well as many of the interventions in the SAFER suite of interventions, can be very cheap to implement. And I'll focus on screening and brief intervention. Screening for alcohol use often involves just asking questions, anywhere from 1 to 10 questions about a patient's alcohol use. That can be done for well under $1 US per patient. And certainly if you're spending more than say 10, US dollars per patient, you're probably not doing it right. You can be a lot cheaper than that. And whether you should do a universal screen or whether you should try to do targeted screening across all health conditions depends on the prevalence of the health condition you're screening for. And we've already seen in our opening presentations that particularly in Africa, but in some of the other slides that were shown, we saw it was true in Europe, it's true in the US, that alcohol use, excessive alcohol use, is very prevalent, and prevalent to the point that a universal screening makes sense. We can identify this problem. And then we have something we can do about with brief interventions. And those are also can be very inexpensive, again, depending on who's doing it, from a lay provider all the way to a fully licensed physician, and how long it takes, how many sessions. So there are a lot of variables there, but certainly if you're spending more than, say, I don't know, around $100 for a brief intervention, you can do that more efficiently as well. And some of the things that Joao was just talking about can really help bring those costs down even further. So we know that screening and brief intervention can be cheap, very cheap to implement. But the perceived value of getting people to reduce their drinking is often the challenge, as is the challenge of then articulating to people that even though screening and brief intervention is cheap, it still takes time. And so as we're talking to physicians to get screening and brief intervention widely implemented, we need to convince them that 2 minutes of their time talking to a patient about their alcohol use is a better use of those 2 minutes than talking to them about, say, their sodium intake for their high blood pressure, or their glucose control for their prediabetes or diabetes, or whatever other issues they have. And that's getting at this perceived value. And as Catherine pointed out at the beginning, screening and brief intervention and referral to treatment is really the only one of the safer initiatives that is embedded in the healthcare setting. And it's really the only one that is encouraging people to reduce drinking, as opposed to being punitive, of raising prices, of increasing penalties for drunk driving. So we need to think about how do we articulate these costs and these benefits. And we have several ways we can do that in economic evaluation. And the most common one, and this is the phrase that came up, is cost effectiveness. We see that quite a bit in healthcare. And that keeps the outcomes, the benefits in their natural units, but then looks at the resources used to deliver in money terms. Cost benefit would put everything in money terms, and cost benefit tends to be better for higher level, population level decision makers. Cost effectiveness tends to work better for physicians, medical care providers who see a value to reducing drinking. When we get to the patients themselves, I think that's where we've got to do a little more work and think about how are we going to articulate to patients the value to them of reducing their drinking. And that's, of course, what a lot of brief interventions try to do. And I see that we're at my time, so I want to thank everybody, and I'll turn it back over to Catherine.
Excellent. Thank you, Dr. Bray. So I'll welcome all of the panelists to turn on their videos so that we can chat. And we actually have one question from the audience that I will read and we'll get started with. And this is for you, Dr. Chaguga. Eliza Williamson said, "Thanks for the great panel. I have a question for Dr. Chaguga. I'm curious about the choice to use a 12-step program to address alcohol use in communities. Why was this specific intervention chosen? Can you say more about the socioeconomic component that you included in that strategy?"
Okay. Yes. So first of all, allow me to apologize for glossing over that part. We didn't have enough time to explain. So Kenya and generally in Africa, we are quite religious and maybe spiritual. And the 12-step bit and Alcoholics Anonymous really resonates with who we are and how we are very religious. So that was chosen by the groups at that time. But allow me to say that that was the initial approach by the groups. But last year, with the second round of funding by the donor, we did change the approach. And that's the slide that I actually like jumped over. We did change the approach to cognitive behavioral therapy and psychoeducation that aligns more with the literature now. Yeah, we did sort of change the approach away from the 12-step approach to CBT and psychoeducation. Yeah.
Excellent.
And then the socioeconomic component is something that we do like to add to the group because it keeps the group going. We found that after people meet and they go through the CBT approach, we find that the socioeconomic component is what keeps them. And that usually takes the form of people pulling their resources together. It's very common in Africa. I don't know if it's the same thing in Uganda, that people meet and contribute a certain amount in that meeting, say $10. Say $10, all of them give it to one person one time, and then they use it for something. And then the following meeting, contribute again $10, give it to someone, and then it goes towards something. It's a way of saving and so that helps bring people together. And it's also a way of helping people get out of poverty because alcohol and poverty are so interlinked. And we found that people are able to learn how to keep chicken, do farming, even build a house. We had this lady who was able to build a house, stop alcohol use and build a house just from joining that group. So we found that component actually got people out of both the poverty and the alcohol use.
Wonderful.
I
Thank
hope I did answer your question. Yeah.
Yeah, great job. Yep. So we have a second question. I'll get to you in just 1 second. I want to bring up a topic that's actually really pertinent for low-income settings, low and middle-income settings, and that is unregulated alcohols or home brews. So I want to open it up to the panel. Can you tell me more about home brews, their use, their prevalence, and their impact overall? That includes challenges in regulating them. Go for it, Dr. Kalani.
Yes, so I'll talk about this in the context of Uganda. Uganda is a multicultural country, but despite its size, we have over 54 tribes, and almost every tribe has a different home brew, that depending on the region, and so these home brews are made from different products. There are those that are made out of millet. There are those that are made out of cassava. There are those that are made out of sweet bananas and so on and so forth. So and there are cultural values attached to some of the home brews. And so the concentration of alcohol varies, but the common fact is that it's all alcohol. Some, of course, that are fermented by yeast. You can estimate the alcohol percentage may not exceed 14%, but others are distilled but still made locally, and they go on up to 20. They even make local liquors in that regard. So it is quite difficult to regulate and even identify, to confirm the alcohol content of these home brews, because to some people it's culture. I'll share an example where I come from. When a child is born, the first drink they put in their mouth is a local brew, and I probably tasted that as well when I was born. And it's very difficult to tell that culture that, stop using this. And so even I remember as we're trying to establish the alcohol control bill or law, one of the aspects that was very difficult to touch or very dicey to talk about was the regulation of the home brews. And yet this unrecorded alcohol is widely used, and it's usually like a gateway to alcohol. They start with the home brews and then ultimately graduate to hard liquor and a lot of distilled alcohol that is at that level. So it's widely used. It's estimated that it's the most, it's even more used than the registered or formal alcohol that are made by the beer companies. But it's quite difficult to regulate because it's deeply embedded in our social cultural fabric or norms. Yeah.
Amazing. Thank you, Dr. Kalani. Dr. Bray.
Yeah, I'm going to keep mine short so I can let some of our other panelists really speak to this. But as we're hearing these responses, I want people to keep in mind that these perceptions of the home brews have an impact on the patient's thought about the value of reducing their alcohol use. It ties into, again, to that economic concept. And if we think about the fuller suite of safer initiatives, it's really hard to increase taxes on home brews when people aren't buying them in the first place. So this really is a critical issue as we think about, alcohol control and we need to think about asking people to reduce their alcohol use without asking them to change their culture. And that's often something we don't do a very good job of doing.
Excellent. Thank you. Dr. Madundo.
Thank you. Yeah, I remember this statistic because it was outstanding to me and astounding. But about 85% of all alcohol consumed in Tanzania is local brews. So when you think of whiskey, gin, beer, wine, all of that is less than 15% of the alcohol that is being consumed. Alcohol production or homebrew production specifically is largely tied to the socioeconomics of many Tanzanians, because Tanzania is a country that relies heavily on farming or on agriculture. And many of these home brews are produced from maize, coconuts, wheat, and things like that. And so the alcohol in itself is a source of income, but it is also strongly tied to people's normal way of living. And it's also the cheapest form of alcohol in many cases. And so I spoke earlier about adolescents. Adolescents will also obviously look for the cheapest kind of alcohol. And this is readily available because it's often produced in homes. About 10 years ago, Tanzania passed a ban on alcohol sachets. So there were these little plastic, about 100 milliliter packages of alcohol that you could buy very cheap on the street. Those were banned, but alcohol retailers, to kind of circumnavigate this challenge, started repackaging high alcohol volume type of drinks into small containers, so selling shots. And these shots are obviously unmarked, also very easy to hide, very easy to transport. And so it's also one of the big challenges facing adolescents right now, is that it's so easy, affordable, and it's a very lucrative business as well to pull in adolescents and just be able to capture them so easily. Yeah.
Excellent. Thank you, Dr. Madundo. And Dr. Kalima.
Yeah, thank you very much. I would like to speak from the health perspective. Not a lot of research has been done about the components or the ingredients of these local brews, but from a few sources, there is evidence that there are a lot of impurities. Obviously, we know that there's no safe amount of alcohol, even if it's regulated and properly monitored. But we have experienced a lot of health hazards, and we have, for example, cases of people who who die because of acute alcohol intoxication. We have cases of people who go blind and get injuries. So I think the issue of informal alcohol is one of the reasons why we have a lot of unintentional injuries attributable to alcohol. The other perspective stems from the treatment component and highlights or underscores the need to intensify our research in the context of managing alcohol problems in low and middle income countries, because you'll find that the quantification of this alcohol becomes a problem. In my cultural setting, you find that people drink from a big pot, and you can find like 10 people surrounding a pot, and each one is having a long straw. And if you have to measure the alcohol alcohol consumption per person, it becomes a problem. So some concepts of brief intervention have to be really evaluated and scrutinized in the African concept, because it may be difficult for someone even to quantify the amount of alcohol that they take. And I feel this is a virgin area that can attract interest of researchers.
Excellent.
Over to you, Catherine.
Perfect. Thank you, Dr. Kalima. And I love the same question, multiple different viewpoints. So thank you so much for the panel. We have one other question that's in the list that maybe it'll be a quick one because I see we're running out of time. My understanding is that untreated ADHD leads to a range of adverse outcomes, including a substantial increase in substance use disorders. What is the landscape of ADHD screening and treatment in low and middle income countries? I also would love to have you talk a little bit about mental health and alcohol and your perceptions if we have time for the panel. Who would like to start? And go for it, Dr.
Well,
Jaku.
Yeah, well, I could start by talking about mental health and substance use disorders. From my own experience, because I work in a alcohol and drug abuse inpatient unit, and I've done so for the past 7 years. Those two things are like sisters and brothers. They like each other, and they co-occur and they work together. So we did one study a couple of years ago, and we found that 100% of the patients in the unit that year had a comorbid mental health condition. And the most common was antisocial personality, and then suicidality was high up there, anxiety, depressions, yeah. Those were the ones that were high up there. So those two things often co-occur most of the time. And then also in the mental health unit, we found that 50% of those patients had a co-occurring substance use disorder. So those things often co-occur. Yeah, and the practice generally is to screen for the other. In the drug abuse unit, to look for a mental disorder, and in the mental unit, to look for a substance use disorder. As regards ADHD, honestly, it's not something that we routinely screen for. We don't have the tools to screen for. The child and adolescent psychiatry specialty, at least for Kenya, I'll speak for the Kenyan context, is not well developed. It's not well developed. We don't screen for it routinely. I will know it if I see it, but we don't really have the expertise for it. Yeah. We don't quite routinely screen for it. If I see it in a young child, I will know it. But for an older child and adolescent, I will not be able to know it and, pick it as quickly. But it's true that people with ADHD, especially adolescents, have yeah, they are likelier to have a substance use disorder as opposed to an adolescent who doesn't have ADHD. That is generally the rule, that someone with a mental illness is likelier to have a substance use disorder.
Excellent.
Back to you, Catherine.
Dr. Madundo, and we have 2 minutes left, so we'll make it quick.
Thank you. Yeah. I'll speak more from a cultural perspective, in that there's a tendency towards believing or conceptualizing things like ADHD as something spiritual, something supernatural, something that could be a curse, especially in LMICs. There's unfortunately a lot of shame and a lot of guilt that comes with having a child that is experiencing difficulties, including ADHD, but it also applies to other neurodevelopmental or childhood onset conditions. And so parents, we see that higher than 50% of the families that come to us where the child is of the main concern, they've already been through several other providers, and this could be a spiritual counselor, this could be traditional healer, all seeking support for the same reason. Yeah, and so we know that with ADHD, the earlier the diagnosis, the earlier the treatment, the better the prognosis. But a lot of the time, there is such a delay that kind of intertwines with this shame and guilt and other factors, and this just really affects it affects the progress and prognosis.
Thank you, Dr. Madundo. Dr. Kalani, we have 1 minute. We're finishing up. Do you have another comment?
No, I'd actually lowered my hand, but it's just to agree with Dr. Madundo and Kim that in Uganda it's a similar picture. We lack human resource, particularly mental health specialists, to adequately screen for ADHD in lower settings, and so we only pick up those that have severe symptoms. But also to emphasize that the link between common mental health issues like depression and anxiety and alcohol use is really bidirectional, and so it's not uncommon to find patients with multiple diagnoses, particularly those with alcohol use problems, and vice versa. Yeah, thanks.
Thank you. Thank you. So in terms of wrapping up and giving a summary statement, there's no way that I can talk about everything that we talked about in the last hour and give a summary. What I do want to end with is the positivity that comes from this panel, with the capacity to manage this really complex and interesting challenge. This is a huge burden globally, but the positive things that I'm taking away from this discussion are the fact that we have evidence on how to do this. We understand the mechanisms of what we need to do. And yeah, we get some cool science when we start to think about innovations and how to do it better. But we also have teams that are trained across the world to be able to do this. So I want to thank my team who's here on the panel with us. We are excited. We all work together, and we are excited for future grants together as a team to start to think through these processes, the challenge that are being faced, and trying to come up with innovative solutions. So thank you everybody for coming, presenting, representing not only the amazing work you do in your teams, but your countries and the challenges you face. Thank you to DGHI for hosting this panel and for allowing us to take part. And if you have any questions, please feel free to reach out. Thank you so much, everyone.